Every clinician has learned to initiate CPR, not just clinicians, it's more than clinicians now. The world over, the bystanders and everybody is into CPR. And a lot of emphasis has been put on the awareness, the detailed guidelines have come about and revisions have been year after year. But very few of us, or very few of the people really learn how to stop it. Now, when to stop CPR is equally important and a difficult decision. Almost no specific instructions or algorithms are in place currently, despite having to understand that much. And lack of guidelines also have left a big void, and basically if you have to take a call about when to stop CPR, it is the decision left with the clinician. So it's similar to like you have just taken a flight all across, and after that we're going to land safely, then we're going to go to the ICU for the post-resuscitation care. But what happens if we fail halfway, if there's a problem there? It's just like the story of Ali Baba and 40 thieves, where all of us know, when his brother, he knew the code as to when to code the code and enter the Sim, the cave. But after that, once he was in, he forgot where to come out and how to stop and how to get out from there. So we need a lot of clarity. So in the next few minutes, what we are going to talk about is what are the current guidelines or rules which are in place for stopping CPR. There are a lot of other factors affecting this also, like the location factor, whether it was an out-of-hospital cardiac arrest or in-house cardiac arrest, and what is the action or the effect that's coming about when we apply a BLS, an ACLS, or in some places where we have a double-tier system where both BLS and ACLS could be overlapping, what is the situation there? And what is the ideal time for stopping a CPR, early or late? And finally, what we have always to decide about, the clinician's decision and the ethical considerations which come along with. Now, in the absence of clear guidelines, this guide called SEAS was developed in 2015. It was published in 2015 when a lot of work was still going on. And they had compared all the three different resuscitation guidelines, starting from European to American, AHA, and then the advanced life support systems also. They found that there was not much of clarity regarding the arrest-related factors and the decision-making also. Nothing clear was given as to how the clinician should proceed, except few things that the decision should be made by the team leader. Then you had something about shockable rhythms where you could have gone ahead beyond 20 minutes, whereas for non-shockable it should be coming to less than 20 minutes. And they had given a guide which included clinical features, effectiveness, asking other colleagues, stopping in consultation with the relatives, and explanation to relatives, but somehow this does not click. And thereafter, in the last 5 to 6 years, we have seen a lot of guidelines coming about where they have tried to address the termination of resuscitation. If we talk about the Australian and the New Zealand guideline, they have clearly come out. Obviously, the first is when the patient starts breathing, the ROSC has come about. It is impossible to continue when there is an exhaustion. And then they ask about handing it over to a healthcare professional. And then it is up to that clinician to decide when it is to be stopped. Similarly to what we talked about the clinician's decision again. Now, the AHA talks quite in detail, but they have given very clearly what is the termination rule that is to be applied by when you have a out of the hospital cardiac arrest. And this should be stopped when there is a return of spontaneous circulation, when expert care has arrived, if people are exhausted, the caregivers, if it could be hazardous or dangerous for the caregiver. And then they've also talked about certain reliable and valid criteria indicating irreversible death. Now, what are these? Now, there comes the role of the termination of resuscitation rules. This talks about if a patient who had a cardiac arrest does not have a return of spontaneous circulation, did not have shocks administered before he was brought in for the ACLS or continuation of therapy, and the personnel did not witness the cardiac arrest. In these situations, they advocated that they should guide you for terminating the resuscitation process. Now, how has this come about? This was based on the study by Morrison et al. In 2006, published in NEGM. They had studied 776 patients with cardiac arrest who had a TOR done, that was a termination of resuscitation. They found that the specificity was quite high, up to 90.2% for recommending transport of survivors. In fact, they could say that patients who fitted in this TOR rule should not be transported, and they got to reduce this transportation from almost 100% to 37%, as you can see here. They also had a very good positive predictive value for death, where they said that by application of this TOR rule, they could say that almost 99.5% of the patients would not be actually surviving, even if resuscitation measures were continued. So this was the basis of the TOR, and later on, From 2006 till 2015, it gradually got general acceptability and validation in these three countries, US, Canada, and Europe. And thereafter, it was called the Universal TOR Rules, which was now a part of all the fresh guidelines talking about ACLS and BLS. So very clearly, as per the AHA, it says that if you have a patient where the arrest was not witnessed by the emergency medical services personnel, there was no return of ROSC, or spontaneous circulation, or AD shock was not given prior to having this, if all these criteria are present, you need to consider termination of resuscitation. But if any of the criteria are missing, then you have to continue with resuscitation and transport. Now, don't ask how much of time, so we'll come to that later. And the recommendation comes that it is generally recommended that BLS termination rule should be developed, should be helping in developing protocols for termination of resuscitation efforts at all the different places. And that is how the different guidelines from the different countries have taken this into cue. And they have also mentioned that you should not be changing the ingredients of these three parameters, because if you change, then the whole rule is going to get invalid or unreliable. Now, to make things easy, that was for BLS. Now, if you have to talk about patients who are getting ACLS, as well as a combination of BLS as well as ACLS, there also they made it quite easy. They said that the use of this universal rule can avoid confusion, and people can stick on to the same criteria for deciding end of resuscitation in a patient who is receiving ACLS or a BLS and a ACLS combination. They have mentioned about this 20 minutes time that is normally accepted. I say accepted, not recommended by most of the studies, because they have said that 20 minutes of resuscitation time, if beyond that, we should be stopping it, but that does not hold good with the guidelines. The role of eCPR, insufficient evidence to recommend the routine use of eCPR in patients with cardiac arrest. However, it has some use in case of patients who have had reversible causes of cardiac arrest death as a result of cardiac problems, but there are still conflicting studies. ETCO2 based, we saw the quality of CPR is being measured, but what about the prognosis? In intubated patients, failure to achieve an ETCO2 of greater than 10 millimeter Hg after 20 minutes of CPR may be considered as one of the multimodal approach, but not in solidarity. And it should be always taken into account with other parameters, whether to decide whether the prognosis is going to be good or bad. And no use at all in non-intubated patients. And while prognosticating, before you're going to stop CPR, you should have multiple variables taken into account, not just the ETCO2, the time, the arrest, witnessed arrest, and all those parameters. So that was for out of hospital cardiac arrest. For in-house cardiac arrest, again, the AHA still talks about clinical judgment and respect for human dignity, quite ambiguity left again out here. And in the in-hospital, they talk about decision again being made in a combination of factors and not just on a single factor. Moving on to the European Resuscitation Council Guidelines 2015, they talk about the TOR rule only being applied by defibrillation only EMS. That means not all clinicians can do it. It's only people who are certified and who are having defibrillation, who are doing that. It should be done by them. It is applicable for both for BLS as well as ALS. And they talk about variables of futility to take into account for termination. But as far as recommendations go, no. And they also talk about including this TOR rules in their guidelines, and they have also found that in-house arrest, the TOR rules are less reliable. And they have also talked about incorporating the TOR rules with the eCPR, which is a little different from the HA guidelines. Now, do we have to now say that universal termination of resuscitation rules are universal? So this has been done in countries like US, Europe, and Canada. So how about this application of these guidelines in eastern part of the world? So these are certain studies. This study done in 2013, they studied 495,000 patients, and they used TOR rule for predicting 1 month death after out of hospital cardiac arrest. They found that 99% predictor of very poor outcome were present. That means to say that they had a good probability of certifying patients who would have a bad prognosis, but they also commented that implementation of this new rule still requires validation despite using it on a large number of patients. This study was done in Taiwan. They had 3,489 patients where the survival was in just 5.6%. They did it again on BLS and ALS both. Now the BLS TOR rules had better predictive accuracy and decreased transfer rate as per the study. However, out of that 1.9 to 4.9% of the patients who had survived despite this, that came under the ethical consideration that should we be doing good to them by just ruling them out as a patient where resuscitation is terminated and they come out safely. Then the another study by Cashier et al., this was in Japan, 11,505 patients, again on BLS and ACLS. They found that the non-cardiac patient etiologies with cardiac arrest had a low specificity, this particular TUR test, and they asked to exercise caution in patients who were dealing with non-cardiac etiologies of cardiac arrest. This Korean study also showed that the TUR rule was applied, but they reported just opposite, where they found that the specificity and PP were quite less in this study as compared to others. So that was quite confusing. Now coming to India, this was the guideline put up in 2017 by ISA, and here it has come about. The decision is based on the clinical condition of the patient. It is the clinical judgment and careful assessment of the patient. They have given of stopping CPR when there is 2 minutes, 20 minutes of asystole with TTCO2 of less than 10, which is not validated by other guidelines. There are no guidelines for out-of-hospital cardiac arrest or where monitoring is not available. And finally, the whole thing to say, the decision lies with the clinician. So what is the ideal time? This landmark study, 2012 Lancet, they found to find out the mean duration of resuscitation before termination of efforts. And what they found, that the mean resuscitation time for patients who received ROSC was 12 minutes, whereas it was 20 minutes for not receiving ROSC. And patients at hospitals with longest attempts, 25 minutes, had a higher likelihood of ROSC and survival to discharge. Now what we see here, that in survivors, by 30 minutes, 42.5% of patients had achieved ROSC. That was quite a good number. And in non-survivors, by around 30 minutes, 76.6% of patients had actually been terminated with this resuscitation. So they said that there is a wide variation. They could not give a cutoff value still, and they still proposed a longer duration of CPR, and that was to be based on a clinical judgment. Another study from Korea, they talked about having a cutoff scene time interval, the same time period of CPR. They said that 20-minute time is adequate for survival to discharge and 14-minute for good neurological recovery. While another study from Japan again in 2016, they said that the pre-hospital resuscitation efforts should be continued for at least 40 minutes in all patients wherever you have a bystander witnessed OHA. And then just after the study, another one came about with 3,353 patients in Japan itself in 2017, where they found that the longer CPR duration is independently and inversely associated with 1 month survival and neurologically favorable outcomes. So that means to say that after 30 minutes of CPR, the probability of a 1 month neurologically favorable outcome decreased from 8.3 to 0.7%. So what is the ideal time? Difficult to say. It's quite conflicting and confusing. And finally, if you have to be left with a clinician's decision that is guided by technological imperative, means you have to go ahead, whatever support you have started, nobody wants to end it. There are pressure on the hospital on reducing mortality, that is important also, we don't let people die also. Unfamiliarity of the emergency medical team, how a patient looks, they just take a quick decision without knowing the background or the other situation of the patient. There are other patients' social status, emotions, family pressure, in which some point of time, if people have to be guided by the clinician's decision, they do get affected by that. And very rarely, but still on use, the pre-existing and the current condition that these patients have, that is important to decide as to whether we should be continuing or terminating the resuscitation process, and presence of advanced directives, though if it is available, it makes it quite easy. Then it's also about the rescuer experience, how he would be going about. And finally, none of us want to leave this maneuver of resuscitation because the chances of risk of litigations of incomplete CPR or the resuscitation efforts, and there could be loopholes there, so we just want to continue with the same. So there's a lot of decision bias, and when you have come to this aspect of a clinician's decision making. So just imagine if you have to take a patient for a termination of a resuscitation process, there's a patient with a cardiac arrest who had a well-connected and educated family versus a patient from a homeless and poor family where you have to take a call when to stop resuscitation. Or the other instance, like you still get biased and guided, an 80-year-old lady with metastatic cancer compared to a 25-year-old male with a metastatic cancer, but are the rules different or sticks to the same? To summarize, despite so many guidelines and so much of research and inputs being put up for this particular aspect of when to stop CPR, ambiguity still remains regarding the same. There are a lot of criteria which have been put up, like the termination criteria, the rule of termination rule, TUR, which is still not universal but still being practiced. And finally, at the end, it is only left to the clinician's decision at a point of time when people are time pressured, having time pressured situations of uncertainty, and it's very difficult to take such a decision or a call. So there is a lot of need to take into account the multiple aspects that we have talked about. We stick on to a particular guideline, make it a protocol, and go ahead.